Good morning, everyone. I am Dr. Arun Kumar, Junior Resident in Psychiatry Department in Subharti Medical College. Today, I will be presenting a seminar on signaling signs of organicity and making psychiatric presentation. In this seminar, I will be discussing case scenarios on why the seminar is important and some clues to differentiate between organic and primary psychiatric presentation, respiratory system disorders, cardiovascular and central nervous system disorders, drugs and medications, electrolyte imbalance, endocrine disorders, infections, and some other common disorders. Firstly, some case scenarios. Suppose you are working in an emergency department, and one night a young male brings his agitated brother, stated that his brother is a known case of schizophrenia, and now he is having these symptoms from last 2 days. On presentation, the patient is showing unprovoked aggression towards the hospital staff and thrashing things placed nearby him. So the patient is restrained and directly transferred in the psychiatry ward. In there, the patient were given sedatives to calm him down. The nurse swiftly obtains IVSS and give him dextrose-containing fluids, and the patient's status immediately reverts back to normal. So, what can be the etiology? So, hypoglycemia might be the cause here because as the patient's status was improved after giving dextrose. Let us take another scenario. 25-year-old female feeling anxious and can't breathe, and there is a history of panic attack versus 25-year-old female with shortness of breath and tightness in chest and after 2 weeks postpartum. In the first case, one is dealing with a possible anxiety attack, while the wording of the second example demonstrates clinical suspicion for having pulmonary embolism. So, in both these cases, it is important to rule out the organic cause because the caregivers may assume that a patient with a history of prior psychiatric diagnosis, treatment, or admissions most likely is presenting with a exacerbation of the same condition. Ruling out the secondary cause of psychosis is important because the causation of the psychosis by medical disorder or a substance can dramatically change management and prognosis. Completion of a thorough review of systems may highlight physical symptoms suggestive of an organic cause and helps the emergency physician in tailoring an appropriate workup. This seminar will focus on distinguishing symptoms of medical illness from the primary psychiatric disorders, crucial for providing appropriate treatment due to their frequent overlap. Some clues to differentiate between organic and primary psychiatric presentation. In the organic, the age will be of less than 12 years or more than 40 years, and it can be sudden onset or acute onset. Disorientation can be there, it can be of fluctuating course, there can be decreased consciousness, and most of the time the patient is having visual hallucinations. There is no prior psychiatric history. Abnormal vital or physical signs can be there. In primary psychiatric illnesses, the age is between 13 to 40 years. There is a gradual onset of the disease. Course can be continuous, and most of the time the patient is having prior history of psychiatric illness. There can be flat effect, and the patient is awake and alert, and with a normal physical examination. But it is not mandatory to have these kind of presentations. Now, starting with some organic causes that can present like a psychiatric disorder. Firstly, the delirium. The diagnosis of delirium consists of disturbance in attention and awareness that dwells over a shorter period of time. Delirium tends to fluctuate in severity throughout the day and is associated with additional cognitive deficit like memory, disorientation, language perception that is attributable to a medical condition, substance intoxication, or withdrawal. Delirium may be considered hyperactive or hypoactive, or the patient may switch between the two states. Patient with a hyperactive delirium may present as a hypervigilant, restless or agitated, paranoid, and can report perceptual disturbances and might often be mistaken for primary psychotic illness. The hypoactive form will be present as a lethargy, somnolence, psychomotor retardation, and might often be overlooked by physicians or be mistaken for depression. There are several key characteristics to further assist in differentiating between primary psychiatric illness and delirium. Primary psychiatric illness does not cause decreased level of consciousness, abnormal vital signs, focal neurologic deficits. Delirium has acute onset, while psychiatric illness develops gradually. Psychiatric disorders mostly include perceptual disturbance like auditory and visual hallucination, while visual or tactile hallucination should raise suspicion of medical etiology. In a respiratory system, there are some medical conditions like asthma or respiratory infections that can affect breathing or oxygen level and that should not be immediately recognized as a psychiatric disorder. Symptoms like feeling smothered, closed in might be mistaken for anxiety, especially if rapid breathing is seen as hyperventilation. Patients with respiratory issues may seem panicked or combative, leading to mistaken diagnosis of psychosis or panic attacks. Severe breathing problem can be life-threatening if not recognized quickly. Dyspnea by the far most common presenting symptom reported in 70 to 90% patients of the pulmonary embolism. Pleuritic chest pain is the second most common symptom for smaller emboli, as they are more likely to lose periphery, cause pulmonary infection, and thus generate pleuritic chest pain. Some common organic diseases present in emergency with shortness of breath are spontaneous pneumothorax, pulmonary embolism, pneumonia, congestive heart failure, carbon monoxide poisoning, COPD. Tracheal deviation and unilateral decreased breath sounds should be checked out. Consider risk factor for thromboembolic disease like immobility and underlying malignancy and recognize findings supportive of deep venous thrombosis if present. Specific findings on lung auscultation such as rales or consolidation should be cleared out. Edema in the lower limbs can suspect organic pathology. An exacerbation of the COPD can present insidiously, with hypoventilation resulting in progressive hypercarbia. The resulting somnolence, confusion, and inactivity can resemble an affective disorder. So, the emergency physician should utilize ABG analysis for any patient with a history of COPD and behavior change. The most common presenting symptoms of carbon monoxide poisoning are headache, impaired concentration, confusion, irritability, muscle weakness, and nausea. So, the emergency physician may attribute these symptoms to a simple viral syndrome if the somatic symptoms dominate, while problems with the concentration or irritability may attribute it to anxiety or depressive symptoms. Patients with a serious toxicity may present primarily with a confusion or hallucination. An emergency physician may suspect primary psychosis. Suggestive historical details include headache or other symptoms that repeatedly occur in a particular location or close personal contacts who have the same symptom complex can be suspected as poisoning. Now starting with the cardiovascular and central nervous system disorders. Firstly, the subdural hematoma. SDS patient can present with acute behavior change. Elderly patients are more prone to subdural hematoma due to age-related brain shrinkage and higher likelihood of falls. Even without apparent head injuries, any signs of falls like bruises on the head or extremity should prompt the investigation for possible subdural hematoma. Chronic alcoholics are also at a risk due to falls and potential coagulation problems related to alcohol use. Patients taking warfarin are at increased risk due to potential bleeding complications associated with medication. Cerebrovascular accident can also present with only mood or behavior change. Apathy, paucity of speech, sleeplessness may occur in the absence of any apparent classic stroke symptoms such as weakness, facial drop or ataxia. Detailed neurological examination of all patients with presumed psychiatric symptoms should be done because subtle findings like dysarthria, dysprosody, aphasia, and agraphia are suggestive of neurological and thus organic etiology. CNS neoplasms, particularly slow-growing frontal lobe tumors, can also cause behavior and affective symptoms without focal neurologic signs, and thus their diagnosis often is delayed. Lesions that arise in a temporal lobe and limbic structures tends to cause visual or auditory hallucination, psychosis, panic attacks, and amnesia. If the emergency physician has a high clinical suspicion for neoplasm, further investigation with contrast enhanced CT or magnetic resonance imaging is warranted. Acute myocardial infarction or an acute coronary syndrome. The emergency physician must consider acute MI or acute coronary syndrome in elderly patients with acute delirium or behavior change of acute onset. Their symptom complex may include weakness, lethargy, loss of appetite, decreased mobility. Such, such decline may misinterpret as a depressive symptoms. Physical findings after acute MI may be subtle, such as the S3 gallop or fine basilar crackles of the pulmonary congestion secondary to decreased pump function. A 12-lead ECG should obtain in every elderly patient with a mental status change or psychiatric complaint. Cardiac exams may be required for full medical clearance. The inappropriate admission of an elderly patient with ACS or AMI to a psychiatric floor could be disastrous. Elderly patients with acute MI are at increased risk of complications like arrhythmia, heart failure, and wall rupture. So the next one is hypertension. Hypertensive emergency is a very high blood pressure with potential life-threatening symptoms and signs of acute damage to one or more organ systems, especially brain, eyes, heart, aorta, or kidneys. Caregivers may overlook the vital signs due to violence or combativeness or attribute hypertension to emotional distress, delaying the assessment. Hypertensive encephalopathy can manifest as a generalized depression of sensorium, adding complexity to diagnosis. Now, some drugs and medications. Early onset alcohol withdrawal symptoms may mimic psychosis or mania, with the symptoms of anxiety, hyperalertness, impaired judgment, and hallucination. So, the emergency physician should recognize the physical signs of withdrawal, such as hypertension, tachycardia, diaphoresis, vomiting, before diagnosing it as a primary psychiatric illness. The chronic alcoholics with a nutritional deficiency, particularly for thiamine, can also present with a vernix encephalopathy, with a classic triad of altered mental status, ataxia, and abnormal eye movements. Withdrawal from benzodiazepines also resemble advanced alcohol withdrawal or delirium tremens. Acute intoxication with certain drugs of abuse can manifest as agitation, aggressive behavior, and hallucinations, often resembling psychiatric presentation. Commonly abused substances include cocaine, marijuana, inhalants, hallucinogens, phencyclidine, and MDMA and ecstasy. So, proper history taking and physical evaluation should precede the formulation of any specific diagnosis, as they provide essential insight into the patient clinical context, aiding in the identification of potential underlying causes. Now, the electrolyte imbalances. Firstly, the hypoglycemia. Early assessment of the serum glucose levels is crucial for evaluating altered mental status. Hypoglycemia, if left untreated, can rapidly escalate to a life-threatening condition. Its neurological manifestations span from stupor and coma to agitation and combativeness, while physical signs like tremors, anxiety, diaphoresis, and tachycardia are common. Misinterpretation of these signs may delay diagnosis and exacerbate morbidity. Next one is hyponatremia. Symptoms of hyponatremia primarily involve neurological manifestation due to osmotic water shift into the brain cells that cause edema. These symptoms can include lethargy, apathy, depression, and agitation. Additionally, they may manifest as subtle changes in the mental status like altered personality, confusion, lethargy, and seizure and coma may also occur in severe cases. The next one is diabetic ketoacidosis that can also present with the delirium in individuals with a history of diabetes. Symptoms include increased breathing, dehydration, and decreased blood pressure. A sweet smell of acetone on the breath may be present and can often be mistaken for the smell of alcohol. Now some endocrine disorders. Hypothyroidism. It is caused by insufficient thyroid hormone, often present with a metabolic slowdown and psychiatric symptoms. Severe cases can lead to psychosis, termed myxedema madness. Treatment with thyroid hormone and psychiatric medication can resolve symptoms, highlighting the importance of considering hypothyroidism in psychosis cases, even in patients without primary psychiatric history. Physical findings supportive of hypothyroidism include fatigue, weakness, weight gain, cold intolerance, dry and coarse hair, with corresponding dry, rough, and pale skin, and psychiatric symptoms include depression, hypomania, paranoia, and hallucinations. Hyperthyroidism can also present as a psychiatric illness. It can present in various ways, that includes anxiety, mania, or in severe cases as a thyroid storm, resembling primary psychosis or psychostimulant intoxication. Common symptoms include nervousness, insomnia, tremors, palpitations, difficulty concentrating, weight loss despite increased appetite, heat intolerance, heavy sweating, and a euphoria. Now the third one is Cushing syndrome. Hypercortisolemia in Cushing syndrome can result from adrenal overstimulation by the ACTH pituitary adenoma, ectopic ACTH production from malignancy, or prolonged corticosteroid therapy. Common symptoms include depression, insomnia, decreased libido, while steroid-induced cases may exhibit euphoria, mania, or psychosis. Physical complaints may involve fatigue, weight gain, easy bruising, or polyuria due to hyperglycemia, and signs include central obesity, purple stria, moon face, and hirsutism. Addison disease, that is also known as primary adrenal insufficiency, is a rare autoimmune disorder that affects male and females equally. Common presenting symptoms include weakness, weight loss, GI complaints, body aches, salt craving, hyperpigmentation, syncope, and disorientation. Additionally, psychiatric symptoms such as sleep disturbance, mood changes, and decreased motivation may also occur. Infectious diseases. Firstly, the viral encephalitis. We should also suspect viral encephalitis when a patient presents with a mental status change, seizure, and fever accompanied with headache. Herpes simplex encephalitis is the most common type of focal encephalitis that affects frontal and temporal lobes. These symptoms often include anosmia, olfactory and gustatory hallucination, personality changes, and also can involve bizarre and psychotic behaviors. Chronic meningitis. It presents differently across different age groups. In older individuals, it can lead to mental status changes impacting cognitive functions and awareness. Conversely, in younger adults, meningitis typically does not alter behavior or sensorium, but manifests through symptoms such as sudden, unusual headaches, fever, stiff neck, nausea, vomiting, light sensitivity, and confusion. To rule out the possibility of HSV infection and meningitis, it is crucial to incorporate CT scan, MRI, EEG, and CSF analysis into the diagnostic process. Lyme disease transmitted through tick bites often starts with a distinctive bullseye rash and flu-like symptoms. It can also affect cognition and mood, causing memory problems, difficulty focusing, irritability, and depression. Considering these symptoms, Lyme disease should be primary consideration when diagnosing new onset depression, particularly in areas where the disease is prevalent. Subacute sclerosing panencephalitis. It is also known as Dawson disease. It is a rare form of progressive brain inflammation caused by persistent infection with the measles virus. It develops after measles infection, with a silent phase that lasts around 7 years, followed by gradual neurological deterioration, featuring behavior change, intellectual problems, myoclonic seizures, blindness, ataxia, and eventually death. Its diagnosis involves EEG, CT scan and MRI scan, CSF analysis, and measles serological testing. EEG often reveals periodic complex with synchronous high voltage biphasic waves. Neurosyphilis, it is also called general paresis, often appear a decade or more after the initial syphilis infection. It mainly affects the frontal lobes, causing personality changes, poor judgment, and irritability. About 10 to 20% of the patients experience delusion of grandiosity. As it progresses, dementia and tremors develop, eventually leading to paralysis. Common symptoms include small irregular pupils, tremors, and speech difficulties. So, for patients with the high risk behaviors like multiple sexual partners or IV drug use, it's essential to rule out the neurosyphilis before diagnosing it as a primary psychiatric disorder. Spinal fluid analysis typically shows increased lymphocytes and protein levels, along with the positive VDRL test. Some other common diseases. Wilson disease. It is an autosomal recessive disorder of copper metabolism. Can present with the psychiatric symptoms like depression and mood swings. Early screening, including 24-hour urinary copper and serum ceruloplasmin levels, is crucial, especially if patient shows liver abnormalities to prevent irreversible damage. In niacin deficiency, that is called pleura, it can also cause neuropsychiatric symptoms that include apathy, irritability, insomnia, depression, and delirium. The medical symptoms include skin rash, nerve problems, and diarrhea, and is more common among alcoholics or poor dietary intake. Vitamin B12 deficiency, also called pernicious anemia, can present with a neuropsychiatric manifestation. Mental changes like apathy, depression, irritability, moodiness are frequent. In some cases, vitamin B12 can lead to prominent encephalopathy, characterized by symptoms such as delirium, delusions, hallucinations, dementia, occasionally paranoid features. This condition is termed as megaloblastic madness. Some take-home points. Identifying whether symptoms are psychiatric or have an underlying medical cause is crucial for effective treatment. Some comprehensive evaluation should also be done. This involves taking a detailed medical history, ordering targeted tests like imaging studies or lab tests, conducting a thorough physical examination. Different medical specialties like psychiatry, neurology, and internal medicine may need to work together for a complete assessment. By considering both psychiatric and medical aspects, healthcare providers can develop a treatment plan that addresses all underlying issues. This collaborative approach improves the chances of successful treatment for the patients with a complex and mixed presentation. These are my references. Thank you and have a nice day.